Hello people, in this video let us understand this topic, supracondylar fracture of the humerus. Okay. So where is your humerus, guys? So here in the red you can see the humerus. So where are the condyles of the humerus? Let's mark the condyles now. Here you have the lateral condyle, here you have the medial condyle. So above these condyles, so supracondylar fracture. So here there is fracture above the two condyles. Okay. So this is supracondylar fracture. Now, why is it important for us to read this? Because it is the, in childhood, this is a very serious, most serious fracture in childhood. This is one of the most serious fractures in childhood. It is associated with complications. See, basically, when that child will fall on an outstretched hand and this hand kind of goes behind, okay, the elbow is forced into hyperextension. See, what is flexion? So, make your elbow joint like this. Angle should decrease. Come close to the body is flexion. Go away from the body is extension. But this is normal extension. Full hyper extension will happen. That is the way that child has fallen. So just imagine that will be so horrible to look at probably. So the hand will be, it has to be like this. It will be more like this. The hand. I mean the forearm. Right? So this is hyper extension. That's what they are trying to tell here. This is the most serious fracture. It is not common. It is serious. That is what they are trying to say here. On an outstretched hand, when there is a fall, okay, there is hyperextension of the elbow. So there will be fracture where the fracture above the condyles. Okay. So when the person falls like this, right, where will it break? Here, above the condyles. So that is supracondylar fracture. Here they have shown how the humerus is fractured. This is the lateral view. You can see how it has fractured. Okay. So this is the first type where they are showing where it is kind of the hand has gone back, extension, and this is the flexion type which is not so common. So what is common is this one, the extension type. Extension means the angle would have increased, isn't it? In this flexion angle is less, but that's not very common. The angle increased one is the common extension type. Okay. So what will happen? Where is the fracture? Above the condyles. So what is above the condyles? The metaphysis. So it's the distal metaphysis of the bone. So if this is the bone, you know that this is the diaphysis. The long part is the diaphysis. Below that you have the metaphysis. And then you have the epiphysis. So the distal part of the metaphysis, that is this part, is broken, right? See, there's a metaphysis here also, but that will be a proximal metaphysis, I'm thinking. Do they call it like that? But anyways, the metaphysis, the distal metaphysis is affected. Okay, that you understood. Okay, then. So the extension type is more common, we told you. The distal fragment is extended, tilted backwards. So that's what we showed here. Okay, the distal fragment, whatever of this metaphysis, it has gone backward. So there is extension type. This is more common. Now, what type of displacements are happening to these fragments? The distal fragment is displaced posteriorly, okay, posteriorly or backward shift has happened. So, the fragment has gone posteriorly. Posteriorly means you can see in the lateral view, you can see here, it has got dorsal shift. That's what they are saying here. So, there is dorsal shift and dorsal tilt. This is dorsal shift. The tilt they have shown in slight angle actually. Wait. See this, dorsal shift, it's gone backwards, and this is the dorsal tilt. Okay, let us say we are looking at the right hand, but from inside. Okay, then this one, antero-posterior view, they are showing that it is gone proximal. The fragment has shifted proximal, so it's kind of proximally shifted upward. It's laterally shifted, or it can be medially shifted also, and then there's a tilt here. The tilt they have shown in curve. The tilt is medial tilt. Okay, medial. So what are the displacements? Posterior or backward shift, posterior or backward tilt, proximal shift, that means it is coming closer, the fragment has come closer. See, that proximal shift they have shown in both the things, proximal shift, up arrow. It is coming more close to the body. Medial or lateral shift, so it can be either medial shift or lateral shift, it can be either. There is a medial tilt, that curve is showing the tilt, and internal rotation again can be there. Okay. So look at the X-ray. In this, if it has to be a medial shift, in case it has to be medial, if this has moved actually medially, then I am thinking this should be left hand if this is medial shift, isn't it? If it is medial shift, it has to be left hand according to me, right? So how will the presenting complaints be? It will be a child who has had a fall and there is pain. There is pain. Highlight pain, please. There is pain. Wait. There is pain, swelling, deformity, inability to move the affected elbow. Okay. When it is early, immediately if you see what will happen, you will see before the swelling happens, okay, you will see that there is posterior prominence of the elbow. So whatever is there at the back, right, that will be more prominent because of the backward tilt of the distal fragment. And whatever 3 points are supposed to be there, that relationship is maintained like in normal elbow, but the posterior one will be more prominent. Okay. Then once the swelling sets in, it is very difficult to see these signs. So you should always check for the radial pulse. Okay, you will have to check the pulse of this person. Radial pulse, you know how to check, right? Or you don't know. So open your right hand and put your fingers here near your thumb, wherever they are shown, and feel the pulse. That is radial pulse. You should be able to feel the radial pulse. And on the other side, near the little finger on that side, you will be able to feel the ulnar pulse. Have you ever felt the ulnar pulse? Because radial pulse is very easy to feel. Ulnar pulse, try it, okay? So these two pulses are very important, guys, because, where are we? Go back to the textbook here. So basically the ulnar and radial pulses, if they are not there, what does it mean? It means the artery is affected. There is injury to the artery. Which artery is supplying and making branches into radial and ulnar? The brachial artery could be damaged because it's the brachial artery which is going around the humerus. So look at the brachial artery here. See, they've shown here. This is the brachial artery. So imagine if this point is fractured, the brachial artery will get affected and hence your radial and ulnar pulses can be affected. Okay. Now also nerve. Which nerve is injured? Medial nerve, radial nerve. Okay. So now let's go back to that image. So here you have the radial nerve and median nerve is here in the middle. So which are the two things that they are saying will get fractured, which get affected? The radial nerve and the median nerve. These two nerves they are concerned about. If radial nerve is affected, there will be a wrist drop, and if median nerve is affected, there can be a pointing index. Guys, look at this. Now let us look at the treatment. So treatment is, you'll have to decide whether it is a displaced or a non-displaced fracture, whether it is the pulse is affected or not. All this is very important. Okay. First, let us look at the flow chart. So this is the treatment plan if the radial pulse is present. If it is present, if the radial pulse is present, then what will you do? If the fracture is displaced, then you will just do reduction, right? You will do reduction. But if the fracture is undisplaced, you can just put a POP and you can leave it, right? Immobilization. So if the fracture is displaced, if the fracture is displaced, you'll have to reduce it. How are they reducing it? How do you reduce the fracture? Closed reduction is enough, isn't it? Mostly it is not an open wound, means you'll do closed reduction. But closed reduction is not sufficient only. You have to also do some percutaneous K-wire fixation from within the skin. You're not completely opening it up, but some kind of procedure you're doing here. Percutaneous K-wire fixation you are doing with some image intensifier, okay, with the help of some imaging, okay. Then you will cast this, etc., etc. You have reduced it, you will immobilize it. Now look at this closed reduction under general anesthesia you will do if image intensifier is not available. Then after closed reduction under general anesthesia, you will again check if everything is fine and then POP, etc. And if closed reduction is not gone well, again they will do a K-wire fixation, etc. Anyways, the concept is the same. Reduction, basically you will reduction. You will reduce it and you will fix it with K-wire, and also you can give a POP and immobilize and then mobilize. Do you know how to reduce, guys? Look at this. Traction. So they are doing traction with the elbow in 30 to 40 degree flexion. So there is an assistant who is giving counter traction here. Okay. Then some carrying angle If there's some carrying angle, they are correcting it at this stage. If required, the carrying angle of the elbow is corrected at this stage. Then flexion and traction. In traction itself, they are flexing. Is it? Pressure over the olecranon. So you can see here in the thumb or something, they are putting some pressure over the olecranon. We are not going into too many details of this. So that is the procedure. After this, what will you do? You will percutaneously fix it with K wire. Okay. So here's the procedure they are giving for all this. Closed reduction, K wire fixation, percutaneous, traction with the elbow in flexion. Assistant is giving counter traction. Carrying your angle of the elbow is corrected in the stage, then flexion and traction. Pressure over the olecranon. So throughout this maneuver, you have to be checking the radial pulse. Very important. This is all if you can feel the pulse only you are doing, remember. Then you will give the K wire fix, isn't it? Here they have shown the K wire fixing. Look at this. K wire fixing they have shown here in the X-ray. Then this closed reduction and all doesn't work. What you'll have to do, you'll have to do open reduction and K wire fixation. Okay. Now look at this, guys. If there is no radial pulse, what will you do? Look at this. If radial pulse is absent, guys, focus here. Radial pulse is absent. So this is more serious, isn't it? So immediate, you'll do a closed reduction, and then what you'll do, you'll have to wait for the, you reduce it, same closed reduction you will do, wait for the pulse to return. If it doesn't return, what you have to do, if it returns, what you can do. If it returns well and good, okay, fine, then you will treat as other supracondylar fracture. If pulse doesn't return, you will have to check if the capillary circulation is good or if the capillary circulation is bad. Now let us say the circulation is good, then you will just carry on. But if the capillary circulation is poor, then you will have to explore the vessel and internally fix the fracture. Okay, you'll have to internally fix the entire thing, the capillary also, I'm thinking. So basically they are explaining how the vascular injury happens in supracondylar fracture. So guys, now let us look at the complications of supracondylar fracture. So there is immediate complication, that is obviously injury to the artery, and this is very, very important because this will lead to ischemia. Volkmann Ischemia will happen. So imagine your forearm is there, right, that has some flexor muscles, all that will not get blood supply. So there can be Volkmann's ischemia. This further can lead to Volkmann's contracture. This is very important terminology that you should listen to. So this Volkmann's ischemic contracture is a sequel of Volkmann's ischemia. So you can see there's contraction. The muscles gradually are replaced by fibrous tissue which contracts and draws the wrist and fingers into flexion. This is not a, this looks like a wrist drop, at least this one, right? And this looks like a claw hand. It's a combination of both those, it looks like, okay? So this is very dangerous, very serious. That's why in the beginning of this video only they said that this fracture is a supracondylar fracture is a very serious fracture of this childhood. So this, if there is ischemia, what will happen? The muscles which are affected are the flexors of the forearm, we told you, flexor, pollicis, longus, flexor, digitorum, profundus. Okay, so all the fingers are affected, the thumb is affected, then there can be compartment syndrome. Because of the ischemia of the muscle, there can be compartment syndrome. Very serious this is. You have to diagnose this compartment syndrome also. There will be severe pain and you will have to do fasciotomy, etc. We'll come to that. Anyways, now we are talking about the Volkmann ischemia. Severe pain will be there. He'll be unable to move the fingers. Ischemic pain is more than the fracture pain. So there's stretch kind of pain. There's tenderness when you press on the forearm muscles, right? There'll be tenderness. When you press on the forearm muscles, they told you, right? Those muscles, any muscles, just you press on these flexors, there will be tenderness, okay? So this is the emergency of the highest order, they told you. Volkmann ischemia is the emergency of the highest order. Basically, they may be developing the compartment syndrome because of all this muscular ischemia. So that is why they are telling you, remove the external splints, bandages, etc., anything construction, so that you will not allow this compartment syndrome, not the swelling should not happen. And then they are elevating the forearm so that this swelling reduces. But the thing is, one thing here, it is ischemia, and when you elevate, there will be more ischemia. What do you think? But anyways, because of this compartment syndrome and the edema there, they are asking you to elevate the forearm and move the fingers, okay? And if there's no improvement, you'll do urgent decompression by doing a fasciotomy of the deep fascia. So this, you know standard things about how to treat compartment syndrome. So guys, what you will do, you will, there is swelling here, there is a lot of severe pain here in the forearm. So what you will do, you will remove all the bandage, elevate this so that the swelling reduces, and then still if it doesn't reduce, you will do a fasciotomy. You will cut the deep fascia like this so that you will relieve the pressure inside, right? That is Volkmann's Ischemia compartment syndrome, how you will manage. Okay, late complications. So they told you that there are some immediate complications like the artery getting injured. Then you have some early complication, intermediate complication. Now late complication. Late complication is standard for any fracture, malunion. So how will it unite? You tell me how many pieces you saw in that fracture, right? So there can be a Cubitus Varus deformity. Okay. This Cubitus Varus deformity, they are calling it as gunstock deformity. The same Cubitus Varus deformity is often termed as gunstock deformity. This is the deformity. But actually this is a very cosmetic problem only, nothing else. Okay, it's only cosmetic, so no need to worry so much about this gunstock. So here what will happen? Hyperextension at the elbow along with limitation of flexion. So there is an arc movement at the elbow. Okay, change in the arc of movement at the elbow. Gunstock deformity. Where will you see this? In the supracondylar fracture of the humerus. So this is cosmetic only, but if you want to fix it, if it's badly deformed, then you can do a supracondylar corrective osteotomy or French osteotomy. Then coming to myositis ossificans, so basically some ectopic new bone can form. This happens when following the injury, if people have massaged that. Very strange, right? So if people have massaged it, then they have seen that the chances of this new bone ectopic, somewhere else, this new bone formation can happen. Okay. And how will you treat this myositis ossificans? So you will have to rest, put the elbow in rest in above elbow slab you will put. Okay. And then after this 3 weeks of slab, you will ask gentle mobilization. And then in some cases you can excise this myositic bone. Okay. But chances of the elbow regaining full range of movement is little. So this scares me. So you should not massage after the injury, is it? Okay, then coming to Volkmann Ischemic Contracture, we told you that because of the Volkmann's Ischemia, the muscles are replaced by fibrous tissue which contracts, and all this wrist, fingers, everything are in flexion. Okay, it sounds like to me it sounds more like a wrist drop come a claw hand kind of a thing. Okay, so there is marked atrophy of the forearm. Okay. The skin will be dry and scaly. Obviously, there is no proper blood supply. The nails are also atrophic. What is Volkmann's sign? This helps in deciding the cause of the flexion deformity. It is possible to extend the fingers fully at the interphalangeal joint only when the wrist is flexed. So, only when the wrist is flexed, like this one, this is wrist is flexed, only in that position, you can extend, what is it? Possible to extend the fingers fully at interphalangeal joints only when the wrist is flexed. When the wrist is flexed, okay. So where are the fingers extended? These are the fingers extended. Everywhere else I see fingers are flexed only. So only when the wrist is flexed, the fingers can extend, is it? Yeah. Let's read this again. Possible to extend the fingers only when the wrist is flexed. Yeah. So do this this thing. This is Volkmann's sign. So do this, guys. Take your hand and make the wrist drop. Only when you wrist drop it, kind of a thing, when you flex it, flex the wrist, your fingers can extend. Otherwise you cannot extend the fingers, they are saying. This is a Volkmann sign. Okay. Then they are saying one more thing. On extending the wrist, the fingers get flexed. Okay. So there may be hypoesthesia or anesthesia of the hand. That is, these people will have some sensory sensations also lost in the hand. Okay. Then treatment. How will you treat this Volkmann's contracture? How will you treat? Passive stretching of the contracted muscles. That means you yourself should hold and contract the muscles. Sorry, you should stretch the contracted muscles. Volkmann's splint you can use. Turnbuckle splint. So there are so many splints for so many things in orthopedics. Here you will use as simple as a Volkmann splint, turnbuckle splint. Okay. In severe deformity, bone operations can be done. Anyways, for this flexor muscles to be released, there's a Maxpage operation they are saying. Maxpage operation, Volkmann splint, turnbuckle splint, too many words. So this is it about supracondylar fracture, guys. Supracondylar fracture of the humerus. You saw the mechanism. It's the most serious fracture in childhood. When a outstretched hand it falls and there is hyperextension at the elbow, then resulting in the fracture of the humerus above the condyles. Basically the fracture line extends where distal metaphysis above the condyles. Okay, so there can be extension type which is more common. So how will the displacement be? So you can see proximal shift, lateral or medial, and there's a medial tilt, and here also they're showing a proximal shift and a backward posterior shift, and also a internal rotation or a dorsal tilt they have shown here. And the diagnosis is that the child will have history of fall, pain, swelling, deformity, inability to move the elbow. Early, if you see that there will be a posterior prominence of the elbow, that point, but the three bony points will be in same relationship as a normal elbow. And after some time when the swelling develops, you cannot see these signs. It's very important to check the radial and ulnar pulses because the brachial artery could be damaged, which is an early complications of this supracondylar fracture of the humerus. So if there is injury to median nerve, there will be pointing index sign, and if there is radial nerve injury, there can be wrist drop. So you will do X-ray and you will see the same type of displacements that we told you. And then how will you treat? Basically you will do based on whether the pulse is there or not. So whether the pulse is there or not, you will anyways do closed reduction. After closed reduction, at least the pulse should come back. If there is pulse is not coming back, then you have to be very careful about it. We'll come to that. But if pulse is there, let us say, then you can do closed reduction, percutaneous K-wire fixation. Okay. How will you do the closed reduction that they have shown here? You will use traction with the elbow in 30 to 40 degree flexion. There's counter traction by an assistant. Then there is flexion and traction. If the carrying angle of the elbow you can correct in the traction only. Then flexion in traction, flexion, remember. Flexion in traction, and then you have the push with thumb on the olecranon. Okay. So then they'll put K-wire and all and fix it. Okay. Then if this closed doesn't work, open reduction as usual. So this is where they have shown you the K-wire fixation. So you looked at this flow chart. If the pulse is present, how you will manage? Same closed reduction, K-wire fixation, etc., etc. If the fracture is undisplaced, you can directly do POP cast. If the radial pulse is absent, then you will do closed reduction and wait for the pulse to return. If pulse does not return, then you will just check if the circulation is good, then you can wait. If the circulation is not good, then you'll have to explore the vessel and internally fix. Okay. What are the complications? Immediate complication, you have this injury to the brachial artery. This can early it can lead to Volkmann Ischemia, which will be very, very dangerous complication. It can lead to Volkmann's contracture, compartment syndrome, etc. Then injury to nerves can be there, like we told you, wrist drop and pointing index, etc. Then coming to which muscles are affected because of Volkmann's ischemia, the flexors are affected. Flexor, pollicis, longus, flexor, digitorum, profundus, etc. There can be muscle ischemia leading to compartment syndrome. So here the patient will have severe pain which is not in proportion, right? What do you call that? Then he is unable to move the fingers, etc. There is stretch pain, there is tenderness, okay? And when you passively when you extend passively, he will have pain in the flexor aspect of the forearm. This is important. Okay, he'll have pain in the flexor aspect of the forearm when the fingers are extended passively by you. Then how will you treat this Volkmann ischemia? It is of emergency, right? And you will have to remove all these bandages, decompress, etc. Fasciotomy you can do if required. Then late complications, there will be malunion. This is a very common complication. There can be gunstock deformity or Cubitus Varus deformity. Okay. But this is only cosmetic. If you want, you can correct it. You can do French osteotomy or supracondylar osteotomy to fix that gunstock deformity. Okay. Then myositis ossificans, whenever they massage this part following the injury, there can be some ectopic new bone formation called as myositis ossificans. This will lead to stiffness. So you can give some above elbow slab and rest the elbow for 3 weeks, and then you can do gentle mobilization. Or you can go and exercise this ectopic bone. However, the chance of regaining full range is less, they are saying. Okay, the stiffness may not go away fully, they are saying. Then we told you the Volkmann ischemia can lead to Volkmann Ischemic Contracture, that is VIC. This where what will happen, the muscles are gradually replaced by the fibrous tissue, which will contract, right? And the wrist and fingers are in flexion. So you will see the skin is dry and scaly. The nails are also atrophic. There is atrophy of the muscles, etc. This is the Volkmann sign. What is Volkmann sign? Only when the wrist is flexed, the fingers will extend. Otherwise, if the wrist is extended, the fingers will flex. Okay. And also the hand may have hypoesthesia or anesthesia. Again, for this contracture, what you can do, there is some Volkmann splint, turnbuckle splint, etc. So you will have some passive stretching. You can do surgery also, where you can release these flexor muscles. That is called a Maxpage operation. In severe deformity, you can do some more surgeries, okay, of the bones, like forearm bones, carpal bones, excision, etc. So you will have to do all that in severe cases, okay. That's it for now in this topic. Supracondylar fracture of the humerus. Bye-bye.